We are diving today into one of the most frustrating and emotionally heavy situations that caregivers face, and that's feeding resistance. You know the scene. You've planned the meal, maybe pureed it perfectly. Everything's ready, and you bring that spoon toward their mouth, and nothing. Their lips clamp shut, the head turns away, the whole body just braces itself. I mean, nothing feels more defeating than that moment, especially when you're just sitting there thinking, you haven't eaten properly all day. Why are you doing this?
That feeling of defeat is so common. And it's exactly why we have to start this deep dive with a total reframe. The sources we looked at, I mean, they're all rooted in behavioral gerontology and person-centered care, and they are absolutely clear on one thing. Clamped jaws are not stubbornness. They're not defiance. It's not a behavior problem, and it is definitely not a choice to be difficult.
Okay, so if it's not them being difficult, then what is it? What's happening?
It is 100% communication. And if we misunderstand that communication, we just end up escalating the threat. The message behind those clamped lips is usually pretty simple. It's, I need you to slow down and help me feel safe. So our mission today is to give you the evidence-based, compassion-driven tools to actually hear that message and respond in a way that puts dignity first.
Okay, so if it's a threat response, we have to understand what's triggering that feeling of threat in the first place, especially for aging adults, those living with cognitive changes like dementia. What are the sources telling us about the core reasons this happens?
What's really fascinating is that it's rarely just one single thing. It's usually a whole confluence of factors that just create this overwhelming anxiety. When we look at the antecedents, the events that happen right before the behavior, we see about 4 major areas of concern, both psychological and physical. First, and this is probably the one that's most often misinterpreted by caregivers, is just a loss of autonomy. Imagine for a second having no control over when you eat or what you eat or how fast. That removal of agency, it creates deep distress. The second big one is sensory overload. The environment might be too loud, the light too bright.
The TV blaring in the background or something.
Exactly. Or the food itself, the textures, the smells, even the temperature can be overwhelming and trigger a complete shutdown. So it's not just the spoon, it's the whole context.
The whole mealtime experience.
Precisely. Third, you have the physical challenges. And oral motor coordination changes are critical here. As those skills decline, the ability to chew, to swallow, to time those movements correctly, it all becomes impaired. And this leads directly to the fourth category, which is the sheer terror of choking.
Right, and the fear of choking is huge. I mean, it's primal. Even if they're nonverbal, the body remembers and reacts.
It absolutely does. And then you also have to include pain or discomfort. This is often the quiet culprit. Is it a dry mouth? Do their dentures not fit right? Do they have a dental issue? If eating hurts, resistance is pretty much guaranteed. And finally, there's the history of how they've been fed. If past experiences involved rushing or pressure or being forced, the brain builds these long-term avoidance patterns.
This all leads to a really critical distinction the source material makes.
Yeah.
How do we tell the difference between someone who genuinely can't open their mouth versus someone who won't? Because the strategy for how you intervene changes completely based on that.
But
right?
that distinction is vital, and it's so often overlooked in the heat of the moment. If the person seems physically unable to move their jaw, maybe they look a little stunned, or there's a known neurological condition, that points to a motor problem. In that case, you need to consult a swallow specialist. But if they weren't open, meaning the closing is clearly intentional resistance, they're turning their heads, stiffening their body, then the focus shifts entirely. That's an antecedent problem. The environment, the approach, the speed is creating a threat. So our job is purely to reduce the demand. We're not treating a medical issue, we are treating perceived danger.
So if we accept that it's a threat response, then trying to, coax or hurry or force the mouth open is not just ineffective. It's actively traumatic. That's why the sources are so insistent on these mandatory principles for feeding support and dementia care. What are those non-negotiable rules?
The foundation has to be consent-based. It has to be slow, non-intrusive, and just deeply respect-driven. This is not about trying to sneak the spoon in, which, we see attempted far too often. We are building trust. And here is the absolutely crucial, non-negotiable safety rule from the evidence. Prompting must never involve physical pressure on the face. Not the jaw, not the lips, not the cheeks. Never. This isn't just ineffective. It causes pain, trauma, it increases aspiration risk, and it guarantees you'll see more refusal long term.
That rule feels so key. But for a caregiver who's frustrated and rushing, The idea of slowing down feels, I don't know, counterintuitive. Like, if I'm trying to feed someone who's resistant, why would the caregiver script start by putting the spoon down on the table? That feels like I'm moving farther away from my goal.
It feels counterintuitive because our default goal is efficiency, right? Getting the bite in. The dignity first goal is compliance without stress. The second the person sees a loaded spoon aimed at them, the demand is there. By placing the spoon on the table, you immediately remove that threat. The demand just disappears.
I see.
So we use a 5-step gentle flow to restore that sense of predictability and control. We start with what we call the invite, something simple, sensory. This is warm and it smells good. Next is the crucial predict phase you just asked about. I'm putting the spoon right here and you just place it on the table, visible but totally non-threatening.
So it turns the interaction from an immediate imposition into just an observation. Okay, what's the next step for restoring their control?
That's where we actively restore control. You ask, would you like to hold the spoon? We're transferring that agency right back to them. Even if they only hold it for a moment, that sense of self-determination is restorative. Then step 4 is to follow their lead. You only prompt or assist if they start to initiate some movement. And finally, the second they take a bite or show compliance, you fade immediately with some encouragement, like, I'm here if you want help, but you're doing great. This whole structured predictability, it's the antidote to fear.
Okay, so that gentle flow is the blueprint for the interaction. But if they need a little more support, the source material advises using a strict hierarchy of prompts, starting with the lightest, most inviting cues possible. What are those least intrusive methods that gently invite participation?
Right, so we start with cues that lower fear and maximize choice. This is purely sensory or verbal input, letting them see or smell the food without any pressure, describing it, the warmth, the texture, and most importantly, offering paired choices. Do you want the applesauce or the soup first? Choice is dignity.
Right.
If those gentle invitations don't immediately work, we move to a really powerful social cue, modeling.
This is where it's really interesting because the sources suggest that modeling, just taking a tiny bite of the same food yourself, it works surprisingly well, even when verbal instructions fail. Why is that?
It works because even when explicit memory declines, the brain often holds on to the instinct for imitation. It taps into the mirror neuron system. So when you demonstrate the behavior, you're not issuing a command. You're just providing a gentle, nonverbal social cue. Eating becomes this shared experience, not a task, and this can bypass that defensive part of the brain that sees the spoon as a threat.
So we move from a shared experience to shared action. The next level of support seems to center back on autonomy, offering them the spoon to hold.
Absolutely. We often find that adults will resist being fed far more than they resist eating. So giving them the spoon, even if they only eat a small fraction of the bite by themselves, it reduces resistance dramatically. The fear just vanishes.
Okay, and then finally we have the last resort, physical prompts. Given that firm safety rule about never touching the face, what does an appropriate physical prompt actually look like?
It has to be used only after the gentler methods have been tried, and only after you have some cue of consent. Physical prompts have to be slow, light, and above all, easily fadeable. We're talking about maybe stabilizing the plate, or lightly guiding the elbow, or offering support to the wrist if they have a tremor. We're supporting the mechanics of self-feeding, not forcing the final action.
We've established the hierarchy, but the sources flag prompt fading as maybe the single most important part of this whole process. Why is strategically removing assistance so critical?
Because prompting without fading creates absolute dependency. If you always guide the wrist, the person learns, maybe subconsciously, that they can't do that task without your full support. They stop trying to initiate. The ultimate goal isn't just constant compliance, it's learned independence. It's protecting their long-term self-efficacy. You want the skill to become theirs again.
That makes perfect sense. If you keep doing the full lift, they stop trying to lift. But how does this removal look in practice? If I'm guiding their wrist, how do I know when to back off?
We use what's called the fading staircase, moving assistance down incrementally based on what you observe. You start at full support, say, guiding the wrist, until you see them actively start moving the spoon toward their mouth before you prompt. That's your signal. That's when you move down to partial support, which might just be guiding the elbow, letting their hand and wrist do the work.
Okay.
The next step down is shadowing. So powerful. Your hand is near, it's ready to help, but it's not touching. You're acting as a safety net, but the movement is entirely theirs. The psychological shift from being touched to just being shadowed, it hugely boosts their sense of control.
And then you move away from physical support entirely into later cues.
Exactly. From shadowing, you transition to gestural prompts, a simple point toward the food or the spoon, then verbal prompts, try a bite when you're ready. Each step is lighter, requiring less from you and more initiation from them until you arrive at the ultimate goal, independence. The whole process just requires patience and recognizing those tiny moments of initiation as huge successes.
Even with this whole gentle flow and hierarchy, we know real life involves setbacks. So for the listener who's facing that immediate resistance, the jaw clamps shut despite the gentle invite, what are the immediate practical troubleshooting steps?
First, look outside the interaction itself. Change the environment. If resistance suddenly spikes, move to a calmer, quieter spot. Adjust the lighting. If the environment is causing a sensory overload, no amount of gentle prompting is going to work.
Right.
Next, try offering tiny microbites. A big, full spoon can look and feel incredibly threatening. A tiny little sample is way less daunting, and it can break that cycle of refusal.
And you mentioned autonomy recovery is huge. What about the controversial topic of, say, table etiquette versus finger foods?
Autonomy recovery is always more important than adhering to traditional table etiquette. If they're willing to eat food with their hands like pieces of fruit or cheese, the recovery of autonomy just skyrockets. So switch to finger foods immediately. That eliminates the spoon threat entirely.
What if they verbally resist? They say, I'm not hungry, even though they haven't eaten properly. Arguing about their hunger levels is probably counterproductive.
Oh, it's totally futile, and it dramatically escalates the demand. Instead, we use paired choice prompting, even when they say they're not hungry. You acknowledge their refusal of the demand while still offering food on their terms. So you'd say, I hear you, but perhaps you'd like the warm applesauce or the cold applesauce. Choice bypasses the resistance without forcing them to admit they're hungry.
Now, for the hardest moment, physical resistance. They swat your hand, they push the plate away. The caregiver instinct is to push back or maybe rush the next bite in. What does the research say we have to do?
You must stop. Completely, immediately. Pause. Take a deep breath and reset the environment. Physical resistance is an unequivocal communication of overwhelm. It's trauma. If you escalate force, even subtly, you just increase the behavior long term and you severely compromise trust.
How long a pause?
The required pause is 5 to 10 minutes. That's long enough for the trauma response to subside and their emotional state to reset, but it's short enough that the routine isn't totally abandoned. And this brings us back to time. A meal for someone struggling with this can easily take 45, even 60 minutes. Your primary goal has to be compliance without stress, and that demands patience, not efficiency.
And let's cover one last piece of communication. Spitting out food. Is that an insult? What's that about?
Never. Spitting is simply communication that the texture or the taste or the temperature is wrong. They're giving you clear feedback. Do they resist crunchy things? Do they prefer smooth purees? Just observe those patterns and adjust the food. Maybe try silicone-edged spoons, which are less harsh on the gums.
Finally, we need a script for family members or even other staff who don't understand this approach and they just think the person is being stubborn.
The best way to phrase it is to remove the character judgment entirely. Just say, it's not stubbornness. Their brain is protecting them from a demand they don't understand or find threatening. Our job is to change the environment and the interaction, not force compliance onto the person. It shifts the blame from the individual to the method of care.
This entire deep dive has really been about recognizing a profound shift that's required. We have to stop thinking about the mechanical task of just getting food in and start focusing relentlessly on reducing the threat. Every moment is an opportunity to either build or lose trust.
Exactly. The road to eating with dignity involves consent, control, slowness, and that critical commitment to fading assistance. These principles ensure that compliance is achieved through trust, not through coercion.
I think the ultimate takeaway we hope you carry with you is simple but profound. Hunger never outweighs dignity.
And that leads us to the final provocative thought for you to consider. The source material consistently suggests that the jaw relaxes when the demand disappears. So if you find yourself consistently encountering resistance meal after meal, how might you restructure the entire routine, the seating, the timing, the smells, to eliminate the perception of demand entirely, long before that spoon even enters a room? How do you re-engineer the whole environment to make the meal feel like an invitation, not an imposition?